professional obligations relating to records keeping. So in terms of introduction, as Sister Irene already mentioned, records keeping is quite important to us as nurses, midwives, and health professionals. So in the clinical environment, with many of our the demand of nurses' times, sometimes it becomes quite difficult and challenging for us to find time to put our records together. But it is a very important part of our role as nurses to keep documentation and records at all time. All documentation and records keeping is relevant according to the NMC 2022, as this forms part of our nursing process, which is, our assessment when we start admitting patients in, our assessments that we do for the patients, the nursing planning, the implementation of the plan, and also evaluation of care, which is our monitoring and reviews. So these are all vital things that we do as nurses, and for that reason, very important for us to keep records at all times. So what is a record? So a record is a collection of information that is unique to an individual. It ensures that the client is correctly identified and that they receive the right treatment. The information from Data Protection Act 2018 defines records as which consists of data concerning health. So it could be the person's, health history, their background, what medication they've been on previously before coming into the hospital or coming into your care. It also describes record as something that we have of a person by a health professional in connection to the patient's diagnosis or the care or treatment of the individual. Good record keeping is vital because it forms part of an effective communication in nursing and integral to promoting safety and continuity of care of patients and clients. And this is by the Royal College of Nursing. So we might be wondering, what classifies as a record. So there's different forms of records, and sometimes, professionals forget that the conversations or the emails or the text messages that we might be sending to clients or patients, they form part of a record, and that could be used as an evidence or a document when it comes to legal process. So the NMC refers to many types of records, and which have been listed below. So it could be emails. So if you're in acute or community, I'm mostly in the community at the moment, and emails form part of, the chunk of our records that we keep. Correspondences between yourselves and other multidisciplinary team, they all classify as a record as long as it's pertaining to the patient's health or the care that you're giving to that patient. It could be incident reports, day texts, incident risks that have happened in the care whilst you're giving care to a patient, or it could be, based on a record that has not been written that you're day texting. They all form part of a record. Then it could be videos. It could be photographs. So if you're treating a patient that has a wound, you might be taking pictures, and those are all evidence of records to show, what care that you have given to the patient, how the patient came, what the wound looked like, and as you're giving your care, what it is looking like at that present time. It could also be text messages. So those of us in the community, it could be, messages between yourself and the client or a patient, clients canceling appointments, mostly in the community. All these would serve as a trail of evidence to show if there's any issues about non-compliance or why a patient's care has been delayed. These text messages can be used as proof of records. Then it could be tape recordings of telephone conversations, letters to and from other health professionals. So on the acute, it could be, correspondence from physios, from OTs, from GPs, that is pertaining to the patient or the person that you're looking after. Then it could also be laboratory reports, x-rays, or printouts from monitoring equipment and incident reports and statements. Okay. Then we're moving on to the golden rules of effective records keeping. So patient and client's record should always be factual, consistent, and accurate. When we're putting up records, we shouldn't be subjective or write records pertaining to our feelings or unconscious biases that we're using according to how we perceive a patient. It should be factual. So what is actually happening to the patient and not what we feel might be happening or what we think the patient might be going through. It should be consistent and should be accurate. Records also should be written as soon as possible after an event has occurred, providing current information on the care and condition of the patient or the client. Yeah, so we don't need to write records. We are expected within 24 hours to document our records, and that's what we refer to as contemporaneous records keeping. If for any reason you're not able to document your records within this space of time, then you should be able to, be responsible and write the reason why this has not been achieved. And always make sure that you clear that what you're writing now is, a retrospective record that you're putting down and you sign for it as well. Yeah. Another golden rule is for records to be written clearly in such a manner that the text cannot be erased. So we encourage to use, if it's paper records, we're using a black pen. At the moment, we're doing a lot of our records, electronic, but there are times when, I would say again in the community where we've got baby record held books, we're using, written records. You need to write clearly so that it cannot be erased. If there's any space left between your records and another professional's record, you need to make a note or sign it out so that it does not merge with, a different clinician. It should be clear and no other additions can be put on there. Also, records need to be written in such a manner that any alterations or additions are dated, timed, and signed. So if for any reason you have to go back to add anything or to add any additions, just make sure you put a signature and a date on there to show that, it is you that has come to make this correction or alteration.
Sorry to interrupt, Henrietta.
Yes.
Slides don't seem to be moving, and are you able to bring us to where you are, please? Thank you.
Okay. So did it just move? I'm on the golden rule to effective records keeping.
No, they haven't moved at all, and I've been trying to, but then I haven't been able to control it. So if you can do it from your side because you are sharing it. Sorry.
I apologize because I couldn't see from where. Is it possible to tell me which page, or is it from the beginning?
Yes, from the beginning, and I've been trying to, but I haven't been able to. So I think because you are sharing, so.
Right, because it's moving from my end here. Hold on. Apologies, everyone. Let's see. Is it possible that you share yours from your end? Let me end this show and restart.
I haven't got.
You haven't received it. Okay.
That's it.
Has it moved now?
Yeah, that's it. Yeah. So now on learning outcome, introduction. What is a record?
Oh, I'm really sorry. I didn't realize it wasn't moving.
It's fine. It's fine. I tried to see if I can do it here, but because you were sharing, so.
Right. Okay. So it looks like if I share it as a single page, that's when it's not moving. Okay.
Sorry about this, everyone. This is technology age. Sorry.
Yeah. Okay. Okay, so we've gone over the forms of records.
Yeah.
We're on the golden rules.
Yes. Yeah.
I'm sorry, I may have to share it this way because when I'm doing it in a single file, that's when it's not moving. So apologies for the busy screen. Okay, can you see it now?
We can see it now. Thank you very much.
Thank you for bringing my attention.
Yeah.
It's okay. So we're getting to the bottom of the golden rule. So we just spoke about it should be written in such a manner that any alterations or additions are dated, timed, and signed by the person that is making these alterations, and it should be accurately dated and signed with your signature alongside the first entry. So if you've gone back to put in any other entries, please do make sure, as a golden rule, that you put your signature on this entry that you're making and let it be dated. Then also, it should not include any abbreviations, jargon, meaningless phrases, irrelevant speculation. So nurses, we're really bad at using a lot of abbreviations, which we'll go over a few whilst we're completing these slides, and also speculations. Be factual, not about your feelings or being subjective. Yeah, so irrelevant speculation should not be put in the records. For example, seeing that a mom, a parent, or a client has come in, the partner is smoking, so you feel or it's likely that the woman or the partner might also be a smoker. That is just irrelevant speculations that sometimes nurses might put in our records, which is not needed. And then we're going to talk about some benefits of good records keeping. So good record keeping helps to protect the welfare of patients and clients, as we've already established. And this can be done through promoting high standards of care and clinical practice. So if we're able to keep good records, we have the CQC and audits that is completed at our workplaces, and by completing accurate and contemporaneous records, we're able to keep high standards of practice. If we have new staff members, it encourages them to continue with that high standards of practice, and also that at the end benefits the patient care that we're given. Also, if you're able to keep good records, it helps with continuity of care, and better communication is disseminated through the teams between multidisciplinary and interprofessional team. So the patient that is under your care may move on to another department, another area, may move on from acute into the community. So if there's no good records that is kept, no communication, it bridges a gap, and the other professionals on the other side may not be able to offer an effective continuity of care. So that's another good benefit of effective record keeping. Also, it gives an accurate account of treatment and care planning delivered for that client or for that patient. So from the get-go, from the start that the patients are admitted, you're taking their history, you're taking their background, any health conditions, any medications that they've had before, and these all help with a holistic assessment to be able to complete treatment for this patient. If there's any information that is not recorded, you leave the patient at risk of duplication of care, or even medication errors, which would also come through whilst we are on this slides. It also helps to detect problems such as changes in the patient's condition at a very early stage. So you might not necessarily be the only one that is looking after this patient. As I have already mentioned, there will be other professionals in their care. So if a patient is deteriorating, so let's say you have finished your shift, you have left, you must have documented clearly what the observations were. So if another person takes over, they're all also able to identify that if there's any deviation from the norm in terms of the community. I look after, the health and well-being of babies. Things around faltering growth is quite relevant if you're doing records keeping, because that tells you, what the child's weight was before, and if there's any dip or any concerns about babies not thriving. So records keeping is quite important and it's very beneficial. Patients' records also provide an evidence of care provided, helping to improve accountability and responsibility. Yeah, so your records that you have kept is an evidence of the work or how you have provided care for this patient, from what you have given them, if it's personal care, from medication. Whilst you've written all these records, that is your evidence, that is your proof to show the care that you have provided. If it's not written, as they say, it has not been done. Yeah, another benefits of record keeping is to help identify risk and enabling early detection of complications. And this has been mentioned. I've just gone over this before. And also it helps to address complaints and legal processes. So we need to be mindful that the records that we're keeping are the informations that we are gathering. However, once there's any litigations or any legal processes, these records become a document that is presented in court, and that is the only evidence that you can stand on to actually, defend yourself, to say, yes, this is the care that I provided for this patient. Now we're moving on to the impact of poor record keeping. So we've spoken about, the golden rules, we've looked at the benefits, and now we're going to look at, what happens really if we're not keeping records effectively. So number one, errors of treatment. We've mentioned about medication errors, so it could be duplication. It could be you giving the patient the wrong medication, the wrong route, the wrong time, because there's nothing to go back to see which what route that this patient's medication should be taken at if nobody's put down as a record for you to go back and refer. So poor record keeping could lead to medication errors. It could also lead to inaccurate care being given due to the poor communication and duplication of care. Yeah, and these all leads to delays in treatment. So if there's a gap in the communication, you are not aware that this client needs to be transferred to another area for something, another assessment, and you're keeping the patient at base, whilst at a certain time they need to have been transported, but because you don't have these records, you don't have these communicated to you, that delays the patient care. Also, another impact is that vital signs and observations may not be recorded, such as blood pressure observation, and even to hand over important information to your colleagues who are taking over, or to the doctors on the ward. These may be missed out if records are not written accurately. It also puts, risks to the health and safety of clients and carers. For example, failure to document moving and handling. So if a client is bedbound or chairbound, and this is not clearly documented anywhere, you take over your shift, you have not read anywhere that this client is bedbound, and you encourage the client to walk, to stand up, and that puts them at risk. So safety is quite key when you have not documented accordingly. Then it could also lead to clients missing pre-booked appointments or clinic appointments. So like I said before, a client that might be on the ward might need to be transferred to another area for further assessment, but all these have been missed out, and you taking over, you have not read any of these, and that delays their care. And also it could lead to poor morale and dissatisfaction from clients and relatives, and that's when complaints are really high. And then the patients sometimes also, and families, they might lose trust in our care, because remember, when they come in, they find themselves as vulnerable. They put their trust in nurses and the carers. But if there's no records, if there's no delays, if there's drug errors, medication errors, poor communication, that really, reduces the trust that the public has in the nurses or the carers. And so we're now sharing, some common examples of, abbreviations that we are really, really using on the wards and in the community. And these may mean anything to anybody at a different sector. So if a client's family, work in another sector, they might have another meaning to the abbreviations that we put in the record. So it's just giving us an example. You can put in the message chat, or you can shout out any other examples that you might be using, whether in the community or in the acute. So we've got HCA, which is, healthcare assistant, BP, blood pressure, temperature. SW is a social worker, physio, full meaning is physiotherapist. DNAR, do not attempt resuscitation. UTI, urinary tract infection. MDT, multidisciplinary team. RN is ourselves, registered nurses. DNA did not attend. BO, and these could mean different things and variable things for people, or even for patients who have worked, in different sectors, and now they find themselves in the hospital. It might mean something different to them. Yeah. Is there any abbreviations that I didn't put on here that anyone wants to put in the chat? If our sister Irene could have a look, and then we could share them, because I'm sure there's loads that might not be here.
CPN, we've got CPN, CMHT.
Yeah.
Yeah.
And can you tell what the full meaning is?
Sister Rita de Graft. Unmute yourself and then tell us.
CMH is Community Mental Health Team.
That's right.
Yeah.
And CPN is Community Psychiatric Nurse.
Okay.
So we've got Sister Rebecca puts in SMMSE. Can you unmute yourself and let us know what this is?
So there's a lot of mental health abbreviation that probably are not here. So a standard mini mental state examination, and I was also going to put mental state.
Shall I add these to it, because it's quite interesting that there's a lot on the mental health side. And I'm sorry, I don't mean to be biased. I didn't put a lot of things for mental health, but it's just that I'm not confident with them. So can you mention that again? So it's SM
standard mini mental state examination.
That's it. And then PMH, I think, is past medical history, isn't it? Or it means something else.
Mm-hmm. Yeah.
Yeah. And then somebody mentioned the community mental health team. Yeah. Yeah. What else?
You got them all the mental health acts. You got those.
Yeah.
Mental capacity.
The DOL's full meaning is
So it's deprivation of liberty. Am I right, Rebecca?
Yeah.
okay. Thank you. I'm sure there will be loads, depending on which area that you're. There's a lot on there, and you can imagine, a patient reading these in their records. And mind you, now patient will go to that. There's acts that permits patients and clients and families to access, these records that we're putting down. So imagine all these abbreviations in patients' records. It does not mean anything to them. So it's really important that if we want to put down accurate records that are beneficial to the patient, and also that keeps us safe as practitioners, we need to be putting them in full. You can write it in full and then put the abbreviation in brackets. And then we're moving on to some common errors in records keeping. Yeah, so one of the main thing is confusing facts with opinions. Yeah, so a fact is a fact. A patient's blood pressure reading is what the blood pressure reading is, but you cannot write that the blood pressure was high or the blood pressure seemed low. What is low? Record what the fact is. What is high? Record what the fact is. If the patient is, laughing a lot or smiling, record what they have said is making them smiling, what has made them happy, and just say the patient reports this is how they feel, but not that you think they're happy because they're smiling. Probably they're in pain. everybody reacts to pain differently. Some will be screaming, some will be smiling, some will be crying, some will be making sounds, but it might not be a factual representation of what you are recording. Then using unclear abbreviations. So we've already gone through some abbreviations. Then inaccuracies, especially dates and times. So always, make sure whatever you're writing, you're documenting it contemporaneously and putting down the date and the time and sign it. And then illegible handwriting. So at the moment, due to electronic records keeping, a lot of our records are typed up, which is great. But unfortunately, there are areas where you still need some paper records. I think in the community, we still use paper records for, babies, the red book, which is the handheld records. But we also keep the electronic records. So whatever you're writing should be clear and illegible. And then using of TPIGs, that is a no-no. We don't use any typics in records keeping at all. You cross it out, you sign it, and then you put the date that you've made this correction. Then omitting times, dates, or signatures, so it is your record, it's your evidence of the care that you have given to the patient. So you should be happy and you should be proud of what you have done, the care that you have given, and date it and sign it to show that I am responsible for this care, I'm responsible for this record, and you have signed it happily. If you've got those that work with students, or those that are on wards where we've got pre-reg students that are studying, always make sure that whatever records that they're doing, you're countersigning it, because you are going to be accountable for whatever the student is writing or typing in. Then delays in completing records. So I've already mentioned that in terms of records that have not been completed within the time frame, please do make sure you're writing and you're clearly stating that these records have been written retrospectively, and also where you're bringing your information from, because if these things happened 2 days ago, I bet you when you're writing your records, there will be things that you would have missing. But if you're transcribing from a note that you made to yourself onto the electronic records, just be clear that you're writing these notes which are delayed, but you're bringing it from records that you made for yourself. And then, so we've spoken about being factual in terms of our records and not using, our own opinions. And some of these times when our opinions come in is when we become, subjective in the records that we're keeping. So somebody would write, the patient appears comfortable, they slept well. What does this mean? What does it mean that they slept well? So try to, identify the patient's perspective. Did they tell you that they slept well? Where is the patient's voice? What did they say? Did they say that the pain was better and that helped them to sleep well? Or did they say, I had a good night because, the sound was low? So when you're recording, it's the patient reported they slept well because they were less pain. They were pain-free. And also sometimes we'll put down, no problems with the wound if we've got a patient that we're monitoring wound care. So be specific, what was noted around the wound, the size of the wound, was there any inflammation that was noted, any dressings, any diagrams attached. Be specific about what you're writing about in terms of the wound. And then we can also see, records saying the patient had a fall or patient fell. Oh, again, be specific. Were there any witnesses? What did the person say that happened? Because you want to hear the patient's voice. How did it happen? Did they slip? Was there water on the floor? Did they hold on to something? And what actions were taken after the fall? Yeah, did you report it? Was there an incident report? Who was there? Who was the witnesses over there? So don't just be subjective, writing short notes, but elaborated and put the facts in there. And then we can also see records saying, patient was very confused. Be specific, confused in what? In time, in place, were they acting, a certain way? Describe what way they were acting. Did they walk off not knowing, their bearings, their surrounding? Be specific and not just put patient very confused, because that doesn't mean anything. And then, patient was uncooperative, or patient is non-engaging, and that's what we see a lot in the community. If the right patient not engaged or non-compliant, be specific. How were they uncooperative? What happened? What did they say? Is there any reasons why they cannot comply? And if there was any reasons given, how are you supporting this patient with the reasons that have been given? Yeah. And patient dizzy at times, give more information. How did you conclude that the patient was dizzy? Were there any observations recorded? Did you take any observations? Was there any follow-up plan? Was anyone informed to follow up? Was a doctor informed? Was a colleague informed? Not just put, patient is dizzy at times. And so what? What do we do with that? Yeah. Barriers to good record keeping. So health professionals, nurses, our role is quite challenging. It's very busy, and sometimes we might not find time to keep these records, but it is important, imperative that we keep records. So some of these barriers that we need to overcome: work overload, pressures resulting in lack of time. Work overload and pressures, I think it's something that we're going to be living with as nurses, because the work comes with the work pressure, but we always need to make time to write our records. And it's about prioritizing and planning, really. Staff may not consider record keeping such a high priority compared to the client care. So some might really focus on providing the care, but they feel, as long as the care is provided, that's the end of it. That is not. If you've not written it, unfortunately, the care that you have provided does not really make any difference. Staff view writing records as a chore. So, especially with this age of IT that we have to type everything, it is a bit tricky for those that are a little bit IT challenged, and they might do everything to avoid it. But it's important that we put our records together. Too many distractions and unexpected events. So you might plan to do your records, then you've got the buzzer going. We've got somebody that is upstairs looking for a professional, and that takes you off your work. So that could be a factor. Then lack of staff training, directives, supervision, or support. So in terms of, electronic records, if somebody is a bit IT challenged, there might not be, or they might not have informed their supervisor or the team about their challenge. So they would not be provided with the support that they need. Lack of resources, paperwork, forms. Staff may also have fear of making mistakes, punishment, breaching clients' rights, possible litigation. So these are all worries or anxiety that some, clinicians may have. But if you look at these anxiety or the worries, it does not supersede what impact it would have on the patient or yourself if these records are not written. Then IT system knowledge gaps and system breakdowns. So I've already mentioned about being IT challenged, and also when there's a system breakdown. So, last year, my trust, we had a really difficult time where our systems were down. So everything that we were doing, we're working, literally blindly. But, you need to work smartly. People needed to do some records and keep it somewhere so that you can always go back and refer to say that these were the health information that I kept for this client or for this patient. You cannot use system breakdown as an excuse. That is really a clinical risk that needs to be escalated. Then, as clinicians, as practitioners, just drawing our attention that we've got legal and professional obligations to ourselves in terms of record keeping. So this is just a few from Public Records Act, which says that is the principal legislation relating to public records. So records of NHS organizations are public records in accordance with Schedule 1 of the Act. So even though it's our records that we're keeping for the client or the patient, just be mindful and know that, at any point, because of these acts, the patients or the families could request to see these records. Then we've got the Freedom of Information Act 2000, and that governs access to management of non-personal public records. And this allows a person to request information from a public body such as the NHS. Then our access to health records, which we're all familiar with, that it gives the right to certain individuals or families to see what has been written about their deceased patient in a hospital or in a care setting. Then we've got our own, professional obligations as we are guided by the NMC, or if it's the GMC, the General Medical Council, around, record keeping. Yeah, so this is designed to guard against professionals' misconduct and to provide high quality care in line with the requirements of professional bodies. So just for us to note that, a patient might be in your care today, they might leave the ward, but that doesn't mean that that is the end of it, because these records that you have written could be kept at length. So for adults, we've got, up to 10 years that these records could be kept live, that they can always, access and in terms of litigation, use it. For GP records regarding children, they can be kept for 25 years. So for us who are in the community or working in GP practices, that could be the length. And then for maternity records, also kept for 25 years. And for us in the mental health setting, that would be kept for 20 years. So overall, it's not to scare us or to deter us from keeping records. It's important that we keep our records, but it's also mindful that we know our professional and obligations to these records that we're keeping. It's always important to be, have responsibility and accountability for the records that you're keeping, because that is the only evidence that you've got to show the care that you've given to the patient, and for you to also prove that that is what actually happened. And that brings me to the end of my slides. Thank you very much for listening, and I would open up for any questions. I don't know if there's any on the
There are no questions in the chat, but thank you very much for a fantastic presentation, Henrietta.
Yeah.
We are really, really, really grateful. And if there are any questions, yeah, we are taking questions.
Okay. Yeah.
Any questions? Anybody's hand up?
Well done. That's all I could say.
Thank you.
Well done.
Yeah.
Well presented.
Yeah.
The only thing I needed to pick up is about how people perceive the thing hands-on is more appreciative than putting down the recording. Yes, as you just mentioned that I've recorded, I've put it here somewhere. They think patient care is more appropriate. Not, but as we all know, until something happens, you don't know how the law will come to you.
Yeah.
And that's
Yeah.
where you need all your records
Yeah.
that you've kept about this person, and then that could, defend you. You can't go a meeting with verbal. It doesn't work that way.
Yeah.
And again, as you said that, the Data Protection Act,
Yes.
that is where people need to protect their patient data.
Yeah.
And the confidentiality is very, very important in our
Yeah.
work.
Yeah.
So these
And
are the